Good afternoon, everybody. Can everybody hear me? Yep. I want to thank Leanne and Tom and all the organizers for having me over. I think I'm probably one or two of the anesthesiologists in the room full of surgeons. That's really great. I hope you can follow what I'm trying to say because I'm an Indian and then living in Houston, so I'm trying to act like a Southerner. You know, the Indian speaking fast and trying to slow down a bit, so sometimes I get lost in that mix. So what I was asked to do is cover the role of pain management strategies on how we can help our patients get back on track earlier. So the next 20 or 30 minutes, I'm going to share what we've done at MD Anderson and our journey on coming to that protocol or pathway, our results so far, the lessons learned, and to impart some of our stories so you, as you're developing your pathway, you don't have to scratch from the start. So I'm a paid consultant for specific projects with Pasira, Medtronic, and Advocate Health, but I'm not going to discuss anything today that will have any bearing to that. So about pain. So not going to go into the details of pathophysiology of pain or what it does to the patient. All of us know that it does impact the recovery. And also in today's environment, there is a lot of discussion on opioid abuse, tolerance, addiction, and the social epidemic that we in the country are facing. Now, the question is, does prolonged or excessive use of opioids in the acute perioperative period can lead to a patient becoming tolerant or having them abuse opioids? That's still debatable, because if you talk to pain psychologists and epidemiologists, there is a certain psychosocial behavioral pattern and a genetic predisposition for a patient to have that abuse potential. As long as we are managing pain effectively, that should not pose a patient a special risk. However, a big problem is our prescription practices. Giving a patient 90 tablets of hydrocodone to take home, when they hardly use for 2 or 3 days, then they have a bunch of medication sitting around, and then that leads to other social issues. So opioid use is rising, but this is the big ticker. You can see in the patients in the 2nd to 3rd decade of life, and the cause of death in that patient population is opioid addiction and overdose problems. So how do we make sure the patient gets back on track while providing effective analgesia and minimizing opioid-related adverse events? So we know it's not enough just to start our strategies during the operation. It has to start in the preoperative phase. It has to continue into the post-discharge phase as needed and appropriate for that patient. Again, our goal is not to avoid opioids. Our goal is to provide effective analgesia by looking at all interventions that we have at our disposal. And if we can do that by minimizing opioids, that's great. That's our goal. So if you haven't seen, there is a society called Prospect. I forgot to put here, it's www.postoppain.org. This is a group of pain physicians and champions who look at all evidence that is out there, and they provide guidelines which are procedure specific. So we have to move away from a one-size-fits-all. For the most part, that's what we've been practicing. Our patient either gets a block, or if the block is not working, it's PCA. And if the PCA is not working, we just keep increasing the dose or add a different narcotic at a much higher dose. So we have to rethink and see what else can we do, and how do we make sure our interventions affect or act on the pain pathways at multiple levels. So instead of just giving a very high dose of opioids, which are acting in a central mechanism, can we institute measures which act all the way from the periphery through the spinal cord and into the central nervous system? And if you just categorize them, then you'll have local anesthetics and anti-inflammatory drugs, and you have alpha-2 agonists, and examples being Celecoxib in our case, but other traditional nonsteroidals as well for anti-inflammatory action. And then you have the gabapentins and Tylenol and tramadol extended release. So this is in the preoperative phase. So all our patients, when they come to the holding area on the morning of surgery, typically it's about 90 minutes prior to surgery. If there are no contraindications, they get tramadol extended release, oral acetaminophen, pregabalin or gabapentin, and Celecoxib. Now, so we have 12 programs going with enhanced recovery, 10 in the surgical service lines and 2 in non-surgical patient population. Each of our programs do not exactly have the same meds because we've asked the programs to design what works best for them, keeping the principles in mind. So as an example, in our liver program, all our patients get these. However, in the thoracic, because they use ketorolac intraoperatively, they wanted to continue that in the postoperative phase. So those patients only get tramadol extended release and gabapentin. Now they decided to use gabapentin because they start the patients on gabapentin before surgery and continue for 3 weeks after surgery, but that's their plan. So we continue the same strategies or the same principles in the intraoperative phase. Pretty much all of our patients in our major cavity surgery get one type of block or the other as appropriate. And if they don't get a block, then they get wound infiltration. And we are a center which uses combination of liposomal bupivacaine and plain bupivacaine in our blocks, except central neuraxial blocks. So here you can see that the blocks that we use are either a paravertebral or a PEC block for all breast surgery. We use posterior intercostal nerve blocks for thoracic surgery, TAP or epidural for all abdominal surgery, and then wound infiltration. So in addition to one of these blocks, patients also get other strategies, which may include lidocaine infusion if we are not using Exparel. They may or may not get IV acetaminophen, ketamine, or nitrous oxide, or dexmedetomidine. So we continue the same strategies in the postoperative period as well. Now the question always becomes, as the group from Johns Hopkins has mentioned, that they've seen a bump in the complications. We'll get to that later. If you're using multimodal opioid sparing strategies, and if you're using more than one, are you using polypharmacy? Well, our thought process is anesthesia is polypharmacy. We moved away from chloroform or ether being the single agent that we used to anesthetize patients with. So we have to use all the available drugs that are disposable in the right doses, in the right infusions, keeping in mind the pharmacodynamic variation between the various patients. So in this study, which was published last year, they looked at the different combinations of drugs that were done across 350 hospitals for the various procedures. And you can see the practice is very variable. And there is a reason for that. And the reason is most of the studies that were done with a single agent that was compared to a placebo. When you do opioid-sparing strategies, typically you're combining different classes of drugs. The effect is synergistic. So the opioid-sparing and effective analgesia results we have is profound when compared to all the other studies you would see for that reason. So I'm just going to show a couple of examples. These are based on the questions we typically get asked. People say, when you're using Celecoxib, obviously the concern always is, in particularly the group like this, is anastomotic leaks. I'm not going to get into the detail because it's very visceral topic, people on both sides of the street get very emotional. But all we can say is there is retrospective evidence and observational evidence that the incidence of anastomotic leaks are high. But there is a difference in the class of the nonsteroidal agents, the dose of the nonsteroidal agents, and the timing of the nonsteroidal agents that we used. As Tom had mentioned, in our practice, we've started using this in early 2013. We looked at all our data. All our patients who get colon surgery get Celecoxib pre-op and post-op starting day 1. All our patients with HIPEC surgery, who typically have multiple bowel resections and anastomoses, get Celecoxib in the preoperative phase, and they may get tramadol in the postoperative phase if needed while they're still NPO, and we haven't seen any rise in anastomotic leaks. In fact, George Chang and I were having some email exchange yesterday. He sent a paper where they've shown that the bursting pressure is lower in rats when they get non-steroidal agents. I sent him another paper which showed there was no difference in rabbits, and my comment was rats, rabbits, and humans, ha ha ha. So again, there is so much heterogeneity in the results of these various studies, it's difficult to draw any conclusion, but your practice is the best guide. So once you have an audit system, once you look into your own data, then you can guide your practice. The other question that gets frequently asked is the prolonged use of Celecoxib or other nonsteroidals and the risk for cardiac events. Again, it's very emotional. There is a lot of heterogeneity in the data that you would see. But here, this is a systemic review and meta-analysis of randomized controlled trials on non-cardiac surgery. And if you look at the effects of Celecoxib in opioid reduction, it certainly favors Celecoxib. And if you look at the pain scores, again, these are compared to placebo studies, certainly favors Celecoxib. So Celecoxib or other traditional nonsteroidal agents, especially when given in more than once, provide you with added benefit of decreasing opioids, providing effective analgesia. So we already talked about anastomotic leaks. So there is a prospective study that's going to be conducted in Britain, and they're particularly going to look at the use of nonsteroidals in the context of enhanced recovery in gastrointestinal surgery. They want to do a 30-day follow-up with the primary endpoint being all complications and a 30-day secondary endpoint being leaks and collections. So we'll have to await as that study is not completed. And when you look at risk of heart failure, that's the other question we get asked. So when we came down this journey, we presented our clinical pharmacologists, our pharmacy people with the medications we feel that's going to help us and ask them to review the literature and give us guidelines. And their conclusions were the same as ours, that is use of tramadol, Celecoxib, and one of the gabapentins, mostly as a single dose in the preoperative period, would not increase the risk for adverse events, yet at the same time may provide some benefits for opioid reduction and better analgesia. So again, if you look at Celecoxib, this is in elderly patients who were taking nonsteroidal anti-inflammatory drugs. You can see that the Celecoxib does not add to the risk of them being admitted to the hospital for heart failure. Similarly, if you look at Celecoxib compared to all other nonsteroidal anti-inflammatory drugs and compare them to the other opioid-sparing adjuncts you would have, particularly in patients who have an inflammatory burden, there is no increased risk for heart attacks. So it's based on the best evidence we have in large trials or meta-analysis, and based on our own experience, we feel pretty confident that use of Celecoxib in the preoperative phase as an opioid-sparing strategy is very effective. Then the question we get frequently asked is, why gabapentin? Is gabapentin better than Lyrica? And do they really improve your pain scores and decrease opioid use? This is, again, a meta-analysis for gabapentin compared to placebo, compared to your controls or the standards. With the use of gabapentin, your opioid consumption in the first 24 hours is markedly reduced. However, the effect on pain is not as dramatic. It still shows modest reduction in your pain scores. And the Duke group did a meta-analysis of reviewing the data on pregabalin, and they found similar results. However, what's interesting here is the pain reduction or the opioid sparing effects do not always seem to be dose dependent. And both the studies, both with gabapentin and pregabalin, have concluded that even one single dose in the preoperative period will provide you benefit in those two areas. So for us, in our practice, we've started using pregabalin 75 milligrams or gabapentin 300 milligrams. And quickly we've seen that about 1 in 5 patients over 65 will get a foggy head condition. They just stare at you, they don't feel like getting out of the bed, and if they get out, they get dizzy. So we've changed our practice that any patient over 65, we avoid any of the gabapentinoids. What about intravenous lidocaine? If your patient is not having a continuous catheter technique for analgesia, especially the University of Virginia group have shown that you doing intravenous lidocaine, even on the floor, up to 48 hours, does not have a risk for cardiac toxicity, provides some benefit in terms of pain control and minimizing opioids. And when they compared the lidocaine infusion to all other elements of opioid-sparing strategies, at least in their initial experience, it has been very good. So this is ahead of print, again in Anesthesiology 27, perioperative use of lidocaine and the effects on post-op nausea and vomiting, ileus, pain, and you can see that the evidence is high for pain after open abdominal surgery and reduction of post-op nausea and vomiting in the PACU. So if your patient is not getting a continuous epidural, and if your patient has not had liposomal bupivacaine, at least intravenous intraoperative use of IV lidocaine is going to help with reducing pain scores and opioid-sparing strategies. So how many medications should we use to get those benefits? This was a study about 2 years old. This is a randomized controlled trial on the effect of double or triple combinations of opioid-sparing adjuncts after women who have had open abdominal hysterectomy. And as you can see, that the combination that has provided the best pain control and the maximum reduction in opioid consumption is this A and M, which is acetaminophen and meloxicam. So at least in this study, and this seems to go even with our own review of data, again in this patient population in our GINONC, that a combination of acetaminophen and a nonsteroidal anti-inflammatory agent, along with some form of block, would provide the best risk-benefit ratio for our patients. This is a conclusion of the ASRA, the American Society of Regional Anesthesia, and they had a special summit to review all the literature and come up with guidelines for acute postoperative pain management in the context of enhanced recovery and opioid-sparing strategies. What they found was the statement that was put forth was use of multimodal analgesia improves postoperative pain control and reduces analgesia-related adverse events. And most of the evidence and most of the experts agreed that use of multimodal analgesia does provide those benefits. So in summary, just coming to the topic of acute postoperative pain management in the context of enhanced recovery, we feel it's very important to have the patient and family appropriately educated on what to expect in the postoperative period, but we also have to educate our providers on the tools we're using to either evaluate the pain and also intervene to provide that effective pain control. I can tell you it's my own experience has been until we always have been a very active thoracic epidural practice. So anybody getting any cavity surgery used to get epidurals as a routine if there were no contraindications. When I used to go and see my patients until about 2.5 years ago, I used to go and tell them, I'm so-and-so, this is the procedure you're going to have, I'm going to put a thoracic epidural, you're not going to have any pain. Now, even if a patient after day 1 or day 2 has some soreness or has a pain at the rate of 2 or 3, in their mind, they're not doing well. Something is wrong because I've told them that they're not going to have any pain. So now I changed the way I go and discuss with my patients. I go and tell them, you're going to have a major surgery, you're going to be sore. You're going to feel like you've done 100 crunches. But what we want to do is help you get out of the bed that same evening. We want you to walk 6 times next day and do hourly breathing exercises. We are going to manage your pain in such a way that you can do all of this. So it's just a change in the way we approach and the way we teach our colleagues and nurses, but it's also how do we measure? It's very important to just not focus on pain scores or opioid consumption, but again, as Tom had said, our goal is to recover the patient. So we have to have some measure of functional recovery or functional interference to see if the interventions we are doing are being effective to meet our goals. So this is a very good slide that you can use any of the measures as long as people understand how to give that tool and the patient knows how to effectively answer on that tool. And the key again is, if again our goal is to enhance functional recovery, the basis is the inflammation. The basis is to minimize the surgical stress. And we know that after a major surgery, you're going to have inflammation and resolution of the inflammation. So while being an anesthesiologist, I strongly believe on the role of minimally invasive surgery in minimizing the surgical stress and helping that patient get back onto their path for recovery. So while all other strategies are important, the purpose of this talk today was just to address procedure-specific opioid-sparing analgesia strategies with the goal that we minimize symptom burden, minimize functional interference, enhance functional recovery for our patient. So I'd come back to this slide, and of all the strategies that are illustrated here, at least in our practice, to have some kind of block, whatever that block may be, which is appropriate for the patient. And if the patient is not able to have any block, and if we haven't used Exparel, then the patient gets lidocaine infusion. So in addition to that block, we rely heavily on acetaminophen and a nonsteroidal as our main strategy. Now, with these strategies, if the patient is not able to maintain the functionality, then they do get an IV PCA, and we have a step ladder based order set to control the pain. So while our goal is to take care of the pain, improve functional recovery, the question always becomes, what is the cost implication? Are these measures more expensive than just using an IV narcotic-based IV PCA? Well, here this is a study from the Advisory Board Company, which was published in 2015, and this was an estimate of what the financial implications would be on a 400 acute care hospital. So what they found was, if you have effective regimens or pathways based on the principle of opioid-sparing strategies, you would have, by a lower opioid-sparing approach, you would reduce the complications by a third, and you would also reduce your length of stay by a third. And that would equate to about $8 million in financial benefit to the organization by opioid-sparing strategies. And so that's the basic of all economic calculations. We are very good at looking at the drug acquisition costs or the equipment or the tools that we use in our trade, but we don't have a very good measure of calculating the benefits by reducing a certain intervention. In this case, how do we calculate the reduction in opioid-related adverse events? I don't know in your institution, at least in MD Anderson, if we have a patient with ileus, the workup is about $2,700 because we go through a series of steps that need to be done and everything is expensive. So in conclusion, our opioid-sparing strategies are not only effective in providing better dynamic pain control, minimizing opioid consumption, minimizing opioid-related adverse events, helping you discharge your patients faster, but in the right setup, it also has financial benefits. So with that, I'll be happy to take any questions now or later.